for that update. We're both founding members of MacGlObAS. So MacGlObAS was formed in 2016. It's a partnership that brings together the clinical, educational, and scientific global health activities of the departments of surgery, obstetrics, and anesthesia at McMaster University. And MacGlObAS was born when members of these departments realized that many of us were involved in global health, education, and clinical work, but that we were engaging in these efforts independently. So the aim of MacGlObAS is to bring us together and to coordinate our efforts. So I want to thank several people for their help in making this event possible. First of all, David Oldenberger. David is our MacGlObAS coordinator. He has been the coordinator of MacGlObAS since its inception. David is someone with many, many talents. David holds a master's in global health. He's a registered nurse at St. Joseph's Healthcare in Hamilton, and he's also a member of the Canadian Forces Reserves. David has arranged and edited all the AV material, and he has worked tirelessly with our speakers. And really, the only reason that there's an event today is because of David's hard work. So first of all, thank you so much to David. Normally, I guess this is where we would clap. Thank you, Brian. That's Zoom assisted clapping. That's awesome. Also, a big thank you to the chair of MacGlObAS, Dr. Brian Cameron. With the pandemic, many global health activities have slowed, but thank you, Brian, for your continued determination to continue the work of MacGlObAS. And also, thank you so much to all of you for joining us. I see so far we have 26 people that have joined us. You know, it's always a bit anxiety-provoking planning an event. You wonder if anyone's going to show up. So thanks so much for spending part of your Saturday with us. And I trust that you will find this seminar interesting. And I hope that you will engage with our speakers and that this seminar will help to either ignite or to sustain your interest in global surgery. So the theme of our seminar today is Constrained by COVID, Global Surgery with a Globe Under Siege. It's a catchy title, but it really gets at the heart of what we want to talk about today. COVID has constrained us in so many ways. It's affected our interpersonal relationships, it's affected our clinical work, and it has affected medical education. And that's true not only here in Canada, but also around the globe. Our intention today is to try and see this reality from the perspectives of our partners from Guyana, Uganda, and South Sudan. The format of our seminar is as follows. We've pre-recorded talks, which we will play, followed by live question and answers with our speakers. I think all of our speakers are available this morning, which is great. The reason we chose this format is because we felt that it was the best way to ensure that our speakers could share their insights and to minimize technological glitches. As we all have come to appreciate over the last several months, internet access is not always as stable as we would like it to be. I'm talking to you from home and our internet has been good for the last few days, so I'm crossing my fingers and hoping that that will continue. We really want this to be as interactive as we can. And so please feel free to type your questions in the chat bar on Zoom. And we will do our best to address them to the speakers during the question and answer sessions. David is going to be collecting your typed questions. But also, we're hoping that you are able to ask questions live, to turn on your mic, turn on your video if you'd like to ask a question. And the way that you can let us know that you have a question during the question period is by raising your hand. So this was something we did a trial run on. If you look on the bottom of your Zoom screen, you should see a bunch of different icons like security, participants, chat. Maybe yours looks a little bit different than mine. But if you click on the participants tab, it'll give a list of all the participants. And underneath the list of names, you should be able to see a blue hand. And that will indicate that you have a question. And then that will let the moderators, either Carolyn or myself, know that you have a question, and we will then allow you to address the speaker. So that's how we planned. I'm sure there'll be some hiccups along the way, but like I had said, I really want to make this as interactive as we can. So our first two speakers for this morning, I'm going to introduce our first speaker, and then we'll hear a pre-recorded message from her, and then we will move right into our next speaker, who I'll introduce at that point in time, and then we'll have a break for questions. So our first speaker today is Dr. Michelle Kamita Smith. She is a PGY5 in neurosurgery at McMaster University. She received her Bachelor of Science from the University of Waterloo in kinesiology, a Master of Science from the University of Western Ontario in occupational therapy, and an MB-CHB from the University of Glasgow. She worked as a foundation doctor, subsequently a neurosurgery registrar for her first 3 postgraduate years, prior to returning home to Canada to continue with neurosurgical training. She has a special interest in pediatric neuro-oncology and completed her PhD in biochemistry as part of the Clinician Investigator Program at McMaster University within the laboratory of Dr. Sheila Singh as part of the Pediatric MacGlObAS program, blastoma program. On her return to residency in 2019, she was keen for a global neurosurgical experience in pediatric neurosurgery, and so Michelle applied and was accepted for a short-term elective at Cure Hospital in Mbale, Uganda, with support from MacGlObAS International Surgery Desk Scholarship. So let's sit back and hear what Michelle has to share with us.
I'd like to thank you for taking the time to listen to how I navigated a global surgical elective in a growing pandemic in Mbale, Uganda. As for disclosures, I was one of the lucky 2019 to 2020 recipients of the MacGlObAS Research Elective Scholarship. The objectives of my talk will be to provide a neurosurgical resident's global health experience in a low-resource setting, as well as to understand the burden of pediatric neurosurgical disease in Uganda, and finally to understand the impact of pediatric neurosurgical care in Uganda and global surgical training during the height of the COVID-19 pandemic. Since very on in my training, I wanted to become a pediatric neurosurgeon. Dr. Ajani, who's one of our pediatric neurosurgeons here at McMaster University, was also previously a program director. He's from Nigeria and did his neurosurgical residency in South Africa. And having never been to Africa and being interested in doing an international elective in pediatric neurosurgery, I asked Dr. Ajani whether we can organize an elective either in Nigeria or South Africa. Initially, there's plans for South Africa, but then last year, he had proposed going to Uganda to Cure Hospital, which is quite famous in and of itself. Myself and making new friends that may require Cure's intervention. But then as I was becoming more comfortable with being in Mbale and navigating the city myself and making new friends, as well as becoming more comfortable in the operating room, the global pandemic continued to progress with this announcement from the President of the United States.
Time address to the nation, the ban will be on some travel from Europe to the U.S. starting on Friday.
This is the most aggressive and comprehensive effort to confront a foreign virus in modern history. I am confident that by counting and continuing to take these tough measures, we will significantly reduce the threat to our...
Time address to the nation, the ban will be on some travel from Europe to the U.S. starting on Friday.
Almost immediately, my friends from the United States were asked by their universities to return home, and as I hadn't heard anything in terms of announcements from Prime Minister Trump and from McMaster University, I was left behind with Abby, who was our local host. I, of course, was absolutely gutted that I was going to have to go home early, and after discussion with the director, it wasn't because I wasn't going to be able to do the surgeries where I was progressing, was mainly because I was making friends and learning to work with my new colleagues there and looking forward to the final 2 weeks. In terms of the children, the new admissions and surgeries were reevaluated for urgency, just like it was here at the Hamilton General when I returned, and all outreach activities were placed on hold. The border closures were implemented in a very strict 6 p.m. to 7 a.m. No one out on the street curfew was implemented in Uganda. My return journey home from Uganda to Toronto was long. It was 40 hours, and I had prepared a N95 mask specifically for this journey home. I returned home to my 2 girls, my daughter Anya, my dog Chloe, as well as my husband, and we celebrated my daughter's 5th birthday just with our family. I became more and more anxious about leaving the house the longer I stayed at home in quarantine, but one day looking outside, I saw my neighbor, who has quite advanced Parkinson's and quite elderly, continue with her daily walks around the block, and I thought, if Mila can do it, so can I. And so I ventured out to Costco, where Lysol wipes, sanitizers, and gloves are all out of stock, and realized, it's not just me that feels this anxiety. It's all of Hamilton, it's all of Ontario, and probably the entire world. I came back to neurosurgical residency after my period of quarantine to a completely new framework. We continued to see neurosurgical emergencies with our new PPE armor and supported each other through this, not only with social distancing, frequent hand washing, and PPE use, but also to communicate all of our anxieties and sharing the information that we had at hand. In conclusion, what I learned first and foremost is that global neurosurgery is the long-term collaborations that we form with our international colleagues. While the global pandemic cut short my neurosurgical operative learning opportunities, the relationship that I was able to form have continued, and the experiences in international electives have helped me grow to see the larger picture and how I fit within the global efforts to manage pediatric neurosurgical patients. Thank you.
Thanks very much, Michelle, for sharing your something about your time. As you could see, there is more that Michelle was prepared to share with us, but for time constraints, we've had to move over a bit of that. And so hopefully in the question and answer period, we can address some of those things. Our next speaker that I'd like to introduce is Dr. Smalana Swan. She is an anesthesiologist and intensivist at Georgetown Public Hospital in Georgetown, Guyana. Now, during the course of her residency, Dr. Swan spent 4 months at McMaster University doing core clinical training. She completed her residency training during the pandemic and will be sharing for us what it was like to balance studying for final exams, caring for COVID patients, trying to learn from overseas faculty who could no longer travel to Guyana, as well as caring for her 2 children. So let's sit back and hear what Smalana has to share with us.
Hello, and thank you for having me. As mentioned, I am Dr. Smalana Swan from the Department of Anesthesia and Intensive Care from the Georgetown Public Hospital Corporation, and I'll be offering a few insights from Guyana on education in the time of COVID-19. So, a quick background. Here we have a 4-year residency program in anesthesia and intensive care. This is a relatively young program in that this was only started in 2013. We have 6 graduates today, and we were fortunate enough to have a collaboration with El Paso University through CASIE, and as such, we now have both local and visiting staff from the US and Canada. And there is also a 4-month elective period that is done in Canada, usually at McMaster University in Hamilton or at Sudbury. And these mainly focus on areas such as cardiac, thoracic, neuro anesthesia, and also some general anesthesia. So, as residents, we were of course greatly affected. We were in our final stages of preparing for exams. Visits eventually were adjusted, they were pushed back. However, there was immense psychological stress from the pandemic, and this, of course, came from working with COVID patients, possibly COVID positive patients, and of course, our concern for our families' safety. We found that it was really near impossible to continue focusing on our study as before, and even our in-house teaching proved difficult. So some of these were converted to virtual sessions. In other cases, um, where the sessions would have continued, um, it was again, I would say the hardest part was to just focus on what was being taught, or what we had to read. There was limited day-to-day interaction with faculty and colleagues, given that now the main focus was to limit contact and time spent in the operating rooms. So as the weeks passed, we gradually adjusted to COVID-19 amongst us. Of course, for us residents, we had our pending exams that was ever present in our minds, and I would say that this required a real greater will and personal resolve to remain focused and on track. Fortunately, we had quite a few Zoom and Skype type sessions, and these were done, of course, with our local and our overseas volunteers. These were mainly focused on exam prep, such as oral questions and answers. Needless to say, there were quite a few technical challenges that were daily occurrences, be it the speed of the internet, dropped calls, maybe even a few blackouts in between. So these were not new to us. Again, these sessions were done from our homes. Many of them were done from, you would say, the comfort of our homes, and this gave the advantage of some time flexibility and theoretically more time to study. However, this proved to be uh, a great balancing act with family, and for many of us who have young children at home from school, this also was pretty challenging. The rest of our exam preparations were pretty much self-study, and unfortunately, even for some, our study leave would have been interrupted, and this was due to the increased demand for anesthesia and intensive care services, especially in the newly established COVID ICU. So, in practice, many residents were required to work in our COVID ICU, and this continued right up until exam. Again, I must mention the mental and emotional toll for residents. And on the positive side, you can say that the ICU management skills for these residents who would have worked in the COVID unit. So those were improved. Some residents claim to have a greater understanding, greater appreciation for their ICU practice. However, this came at a cost of time spent away from the operating rooms and from the focus on anesthesia care and learning. I must also mention that the elective period in Canada has been affected. So since the pandemic, no one has been able to travel. Um, we look forward to this resuming as soon as possible. And I am happy to say that all residents were successful in their final exams. However, many believe that their performance could have and would have been better had it not been for the pandemic. Overall, COVID-19 has significantly changed educational practices as we know it. The new norm is yet to be established. And we do look forward to working with all interested parties to ensure the best standards of learning and practice for our current and future anesthesiologists. So what does a possible future look like in terms of education? And for us specifically to our program, the one major question is whether or not persons will be able to travel. And if not, this would result in one of two major consequences. The first is that there will be a lack of our visiting volunteers. In general, they do offer an immense wealth of knowledge, experience, and different perspectives that contribute greatly to our practice here, not only for our residents, but also to our local educators. So that would be severely effective. And even though they may be able to join us virtually, I would dare to say that it would not be the same as to them being physically present. Also, the second consequence is whether or not our residents will be able to travel to do their 4 month elective in Canada. Personally, and from what I know from the others who have been able to complete this stint, we have learned a lot. We were able to put a lot into practice from what we learned over there. And I do hope that our future residents, our current and future residents, will be able to benefit from this. Thank you. And this is a snap of some of the residents in the pre-COVID era during one of our regional anesthesia training. Thank you.
Thanks very much, Dr. Swan and Dr. Kamita Smith. I've been scanning the chat bar a little bit to see if there's any questions, and I'm going to change the view on my screen to see if there is any blue hands up at all. All right, while you're all still thinking of your questions, I see Dr. Cameron has his hand up and he had typed some questions in the chat bar. Dr. Cameron, you have a question.
Thank you, Joel. Great. I really enjoyed both of these talks. I guess my first question was for Michelle, and I was sort of trying to speed read some of the text messages that were on your slide. And I just wondered, were you able to continue communicating with Ugandan colleagues after you returned, or do you have any other insights about how this was affecting them at the time that just before you left?
Hi everyone, still post call, but yeah, thanks for your question. And yeah, I was able to keep in contact with everyone, which is really nice. Even though I was only there for 2 weeks, I was able to build nice relationship with them, and they were really interested in what's happening in North America and what's coming out. And I guess they weren't getting a lot of information even within Uganda about, where they're going, because they're just locked down. So they're really frightened, and I got lots of messages from the nurses, from the PICU and the PACU as well. And so
that was just a really nice kind of ability to support them even from here and provide them with information. And even after things kind of started to look like they were settling down, they were still in touch with me with the research that I had started when I was out there as well. So that was really nice. Still have that contact.
Michelle, I apologize that for time constraints, we had to shorten your video a little bit. But in the part that we had to jump over, you shared some of the procedures and some of the work that you were involved with. I'm wondering if you could share or could highlight maybe one of the most significant things that you learned or that you were involved in while you were in Uganda.
I think one of the most significant things was infectious hydrocephalus was something we don't really see very much here in Canada. And so just how common it is. And when I asked a lot of questions about why it happens a lot there and how it kind of happens from, the ground roots level where there's cultural practices of, when children are born and they put the dirt onto their umbilical cord that's been freshly cut, and that's one of the roots of infection, and how children present very young with infectious hydrocephalus, and then how they get behind in terms of the curve of trying to treat them, and also availability of places that can treat them. And so they all come to cure, and there's, we would round on over 75 patients, which is unheard of even in the adult service, let alone the pediatrics. And so very busy, and learning how to do the procedures that they were doing there, that the only thing that they knew to do at the time was irrigation, like a ventricular irrigation, in addition to that choroid plexus cauterization that I went there to learn.
Thanks very much. Is there any other questions? I didn't see anything typed in the chat, or does anyone have raised their hand? Dr. Cameron.
Sorry, I was waiting for somebody else to raise their hand too, but since not, I'll ask a question of Dr. Swan. Again, I really enjoyed your presentation, Slimana. My question really was about your experience and your fellow residents working in the COVID ICU. Did you have adequate PPE there? Did any of the residents catch COVID? And I mean, you were speaking about the understandable anxiety of being working in that environment.
Okay, thank you, Dr. Cameron. So yes, most of our residents so far were placed for some time to work in the COVID ICU, and currently I'm working in the COVID ICU. So at first there were some shortages in PPE. Fortunately for those directly going into the COVID ICU, we were able to maintain supplies for those persons. So nobody had to really be exposed in such a way to be working without PPE. Fortunately, now we have a better supply of PPE, so we're more comfortable when it comes to that. However, unfortunately, we have had a few people who contracted COVID-19, a total of four residents, and 3 from the COVID ICU and 1 from the general operating theater. It was due to a patient who was not diagnosed with COVID-19, but after the surgery was done, he was found to be positive, and that resident who specifically worked on that case, he ended up being positive. The other residents who were infected at the time were working in the COVID ICU. It is unclear whether or not this was due to directly from patients there in the COVID ICU, or whether it was from exposure outside of the working environment. However, we do have, I would say we do have adequate PPEs at the moment.
Thanks, Dr. Swan. Any other questions? Smilana, I wanted to ask you, you mentioned at the end of your presentation that there was a couple consequences of people not being able to travel, and that's one of those is the lack of sort of visiting clinical teachers that bring different perspectives. And I wonder, since this has been a significant change in what has been taking place in Guyana over the last sort of 3 years, have you noticed any potential benefits of not having visiting faculty there, you know, a new person every couple weeks? Has there been any potential upsides?
So the potential upside would be persons like maybe a closer interaction with the local staff. We do have close interaction, but then now without the visiting staff, we'll be forced to, you would say, rely more on our own resources and what we have here, and learn how to explore different ways of teaching. So in a way, you know, it can force us then to come up with new ways of teaching, explore hopefully better ideas, and just learn how to work with what we have here. On the other side, I do see quite a few disadvantages. I know from my own interaction with these volunteers, every volunteer that comes, it's a different experience. Different residents would interact differently with each volunteer. When I say differently, you know, their level of what should I say, bonding, or you know, how each resident interacts with a different volunteer would be distinct. And I know that, you know, it's nice to have that sort of constant flow of people, and you know, different persons would motivate you differently. So that's the downside, but you know, hopefully we can adapt if that is no longer possible, and come up with new ways of teaching.
Do you find now, you've recently finished now your residency training, along with I think 2 others that were in your year. Are you sort of encouraged to be involved in more teaching than you were in the past, and do you think you're going to have a greater responsibility?
Yes, I am. After completing my exams and the whole period of preparing for it, I have been motivated, I must say, to help the future residents to prepare, to maximize their time when it comes to preparations, especially for exams. I know it's an extremely stressful time, and for me, my aim would be to make residents more comfortable in their exam preparations, and just reduce that immense amount of stress that I felt during my time of preparation. So that would be my aim. And I'm sorry, what's the second part of your question again?
No, I think you've sort of covered both of the aspects of the question. I was just wondering is sort of what type of teaching role do you think you're going to be going into if there's not as many local if there's not as many visiting teachers?
Yes, I'm very interested in getting residents more comfortable expressing their in terms of like oral questions and answer. I know it has been a challenge for us so far, and I do hope to be able to help us in general be more comfortable with that, and the residents especially.
Okay. Dr. Swan, there is another question for you in the chat bar from Dr. Levis. She's wondering if your training program has developed alternatives, perhaps with virtual education, to replace the 4-month subspecialty Canadian elective.
So yes, we do have some volunteers that we are very familiar with, yourself included, and we have been in contact with those individuals. They have offered their support in whatever way is necessary and possible. So we do have that at our disposal. However, there is no definitive plan as yet in terms of how that 4 months will be replaced.
Okay.
But we do have the available.
Okay, thank you. If anyone else has a question, please type it in the chat bar or raise your hand in blue. Michelle, I was wondering, you mentioned with respect to infectious hydrocephalus, some cultural practices that may dispose to having more children develop this. I'm wondering obviously from the neurosurgical level, you're dealing with an interventional approach. Is there any public health or community grassroots based approach to trying to prevent this problem?
There was some outreach that they were doing in Uganda, near northern Uganda, where they traveled, and that was one of the opportunities that I was going to be able to be part of. Unfortunately, because it was cut short, I couldn't go to one of those outreaches. But they do a lot of education from Cure, and they're all from like the local people who understand and can also speak the language, because there is multiple languages, and which is why rounds took so long as well, because all the parents coming from all the different regions of Uganda speaking all the different languages, and so somebody in the group translating, and so yeah, so there were efforts, because I think that's what we realize is, or they realize is that that education and teaching the next generation would kind of decrease the burden and flatten the curve, as it were.
And just a follow-up question for you, Michelle, from Dr. Levis. Were residency programs in Uganda adapting during the outbreak to continue providing postgraduate education? And have you heard of any changes since you've returned?
So one of the things that I was very surprised with was that there was, in my presentation, I had shown people who were part of the Cure team, and part of the Cure team were medical officers. So they actually didn't have any residents. They were medical graduates, but they were in between getting a residency. And a lot of times it was financial. And a lot of them were looking at Northern Africa or South Africa to get a neurosurgical residency, because Uganda actually didn't have one. So so a lot of these medical officers were there for a while, and I think COVID did kind of delay their start, because one of the medical officers, he was a senior one, got a World Neurosurgical Federation scholarship to go to Morocco. So so that was one of the things that was really surprising, even though there's an amazing place like Cure, that they didn't have a residency there. And certainly, I forgot to say, Dr. Levis, that was one of the things that Dr. Emmanuel Wagoya and Dr. Okechi were actually working on, is trying to build a neurosurgical residency, because even both of them went outside of Uganda to get their training. I think one in South Africa, and the other one actually went to China and then got their training and came back to Kenya for a bit, and then came back to Uganda. So there's a real push for Ugandans to come back and be part of something great like Cure.
Well, thank you very much, Dr. Swan and Dr. Kamita Smith, for joining us and for taking our questions. At this point, we're going to move on to our second panel, and I am going to turn over the hosting chair to Dr. Carolyn Levis, who will moderate the second half of our seminar. So Carolyn.
Thank you, Joel. And good morning, everyone. Good afternoon and good evening. Our next panel will focus on overcoming COVID to provide essential surgical services. And we have two speakers, Dr. Brian Madison and Dr. Eve Nakimembe. And both of these presenters will begin with a video that they've prepared, and then there will be a short live presentation to follow. I will introduce our first speaker, Dr. Brian Madison, and then his presentation will proceed, and then immediately following, I will introduce Dr. Nakimembe, and then following that presentation, we will take questions. So Dr. Brian Madison will be talking on developing partnerships. He is a trauma and orthopedic surgeon, and he is a lecturer from Juba in South Sudan. He completed his medical school at the University of Juba in 2008, working as a medical superintendent before he completed his Master's of Medicine in Orthopedic Trauma residency in Tanzania in 2017. Currently, Dr. Madison is approaching the end of his one-year fellowship here in Hamilton in orthopedic trauma with the Department of Surgery at McMaster University under the guidance of Dr. Brad Petrosor. This fellowship has been supported by St. Joseph's International Outreach Program, and we will begin with Dr. Madison. Welcome.
My name is Dr. Brian Madison. I am an orthopedic surgeon and I work in South Sudan, as well as a faculty member in the College of Medicine, University of Juba. I deal mainly with undergraduate students who are working towards their bachelor's degree in medicine. So that's mainly my focus of work. The medical school at the University of Juba graduates around 60 medical students per year. And the affiliated university hospital is not very big. It has a bed capacity of around 200. For orthopedics and trauma, we have a bed capacity of 20 beds. What I would like McMaster residents and faculty to know about my surgical practice in South Sudan is that it's fairly new. South Sudan just gained independence in 2011. And as we speak, the whole country has a population of 10 million, but only has 6 orthopedic surgeons. And all these orthopedic surgeons are focused in the capital city. So that means there are a lot of people out there without access to orthopedic care. And yet it's one of the biggest problems because trauma is a huge problem back home. Back in South Sudan, people use motorbikes as a means of transport. So there are safety concerns and there are a lot of accidents out there. As well, gunshot injuries are quite common. Being a country which is just out of conflict, guns are everywhere, so we get a lot of gunshot wounds. I found out about St. Joseph IOP program through Dr. Michelle Gert, who was in Tanzania while I was doing my residency. She came there as a volunteer. So that was when I met her, and we discussed about training opportunities, and she told me about St. Joseph and how I can get a fellowship in Canada through the IOP. It took almost a year for me to finalize everything and get back here. You know, getting in touch with people who have a lot of experience with trauma will certainly give me the opportunity to get more skills. This fellowship is more hands-on. As I've said, the process was lengthy, so I had to be registered with the CPSO so that I'm able to scrub in and get more actively involved in patient care, in the clinic, intraoperatively with procedures and so forth. So this fellowship program is, especially in the surgical field, it's very important that you get your hands in. So this is the main difference between the fellowship and the observership that I had. The impression that I had from my time during this 1 month of my fellowship, in terms of patients are quite different here. Back home, patients have 100% faith in the doctor, so whatever you say goes. Here it's quite different because they're more, they go on and Google everything and make sure that when they come, they have a lot of information and you have to clarify more. You have to spend more time with the patient, talk with them and so forth. That's mainly the big difference that I had. But talking about my fellow residents and the fellows and residents, they've been very, very welcoming. The environment in general is quite welcoming. And also the staff, the nursing staff within the hospital, they're very nice. So overall, I had a good experience. If there is anything in Hamilton that really surprised me, is the diversity that I've seen here. I never thought that I will encounter people from all corners of the world in Hamilton. And as a matter of fact, accidentally, I met twice or three times people from South Sudan just walking in the streets. So that's the biggest surprise for me here in Hamilton. For the weather, I'm not very much surprised. I knew it was going to be cold, but maybe I was surprised that I could adapt to it thus far. It's almost 1 month and it's cold, but I'm adapting to it fairly.
Dr. Madison, are you?
Yeah, can Dr. David put on the PowerPoint slides? I'll just have a few slides that I'll go through. All right. Hello again, everyone. Just want to give you a brief talk of recent observations on the impact of COVID-19 at the moment in South Sudan. Next slide, please. So I'll just talk briefly about the effect on surgical care delivery. South Sudan is one of, it's a low income country and we already have a lot of problems with healthcare services to start with. So we had pre-existing constraints with human resources for health, as well as hospital infrastructure and resources. And in the context of COVID, we're talking about ICU facilities, oxygen ventilators, and PPAs. All these are lacking. Also, one of the biggest problems is that accessibility. Not everyone has access to healthcare because South Sudan population is mainly rural. And on the other hand, most of the healthcare services are available in urban centers. So the biggest chunk of the population really don't have access to hospital care. And again, with in the context of COVID, also healthcare funds were rerouted to take care of the impact of the effect of COVID-19. So we surprisingly, we did not see any a lot of impact on surgical care, and this is actually expected because surgical care in countries like South Sudan is less than ideal, and it's mainly focused on emergency and urgent care. But in COVID-19, what we saw cut down was actually elective procedures. So more or less emergency care like cesarean section, laparotomies, open fractures were not greatly affected or are not greatly reduced by COVID-19. But one of the problems that we see everywhere is the problem with PPEs and protection of healthcare workers. We don't have data from South Sudan of healthcare workers who are affected or who got COVID-19 in the line of duty. But to borrow from our neighbor Kenya, they've seen around 25 deaths among doctors from COVID-19. And actually 4 of these deaths at some point occurred in about 24 hours. So this is a big problem, and there is a very big push to try to improve services for healthcare workers to be able to take care of COVID-19 patients. But again, the pandemic actually exposed the fragility of our healthcare system. So politicians at least know that there is a very big problem with healthcare because it actually affected most of them. Next slide. Looking at it from the perspective of medical education, South Sudan at the moment does not have a formal residency program, but we could see the impact on the medical school, which was temporarily closed. And I think it just resumed in the past few months, I think 1 month ago, but it was, teaching was stopped for a while. But on the brighter side, with COVID-19, doctors from South Sudan and doctors who are South Sudanese who are spread all over the world, they were able to come together and do monthly sessions, continuous professional development sessions. It started with topics related to COVID-19, but when that was exhausted, people were already now talking about other topics. So that was a good thing because it brought together people on Zoom sessions and to be able to harness the potential of ICT. And also, we saw for the first time the COSEXA, which is the College of Surgeons of East, Central, and South Africa, was able to conduct virtually an exams in South Sudan, where we had 2 fellows who successfully completed the exams. Previously, the exams are done during the annual general meeting of the COSEXA. That's about it for me. Thanks.
Thank you, Dr. Madison. So our second speaker will actually be presenting live. I'd like to introduce Dr. Eve Nakamembe, who is a senior lecturer and consultant obstetrician gynecologist. She is a clinician, a researcher, and a global health advocate. She is a faculty member of the College of Health Sciences, Makerere University in Kampala, Uganda. She is the director of the Mother Baby Friendly Hospital Initiative of Save the Mothers, East Africa. With over 15 years experience in both global health and obstetrics and gynecology, Eve is a recipient of several awards. Her work focuses on multidisciplinary approaches to reducing global maternal newborn morbidity and mortality, with a specialized training in the area of global sexual reproductive health and rights from the Lund University in Malmö, Sweden. Today, Dr. Eve Nakamembe will be speaking on opportunities and challenges that COVID-19 pandemic present for access to essential surgical services in low resource settings, a case of Uganda. Welcome, Dr. Eve.
Thank you very much. Caroline, and for pronouncing Nakamembe perfectly. Good evening, good afternoon, and good morning, everybody. I hope you can hear me, but in case of anything, just accordingly. I think first recipients of the St. George finished that several years back. I think I was among the people who received that first. And I'm really grateful because I think my elective placement way back in 2008, 2009 in McMaster University really gave me a paradigm shift on what my role and my career path could be in global surgery, low resource settings like Uganda. So I thought that as we look at COVID-19, the pandemic, that it was really important that we look at global surgery amidst the COVID-19 pandemic. But my perspective is really much more into what I'm showing in the next slide. Next slide, please, David. honestly, I think for me, I don't know what you see when you look at this glass. Whether it's, that is what global surgery is going to look like post-COVID-19 pandemic, amid the post-COVID-19 pandemic. That's me in the corner with my colleague, Dr. Varagaini Justus, a senior obstetrician gynecologist majoring in urogynecology. And you will not believe who is in the middle of that picture, a journalist. This was at the heat of the COVID-19 pandemic, and that is in Mulago. I'm a high-risk obstetrician in Mulago, and all the things that my colleagues have talked about, effects on transport, people coming in late, having limited PPE, human resource constraints. The health workers were very psychosocial stress among health workers was really great because people didn't know, will I get COVID? How do I treat it? Is it a death sentence? Especially if you're working in a setting where there's no health insurance. But I also want you to look at this picture of us in Mulago. And Mulago is no different from Sudan, from any other country, I mean, in a developing world. And I think just look at what is on the wall, what the doors look like, what the floor looks like. If you have that mental picture of Mulago, congested, crowded, patients everywhere, you know, and not Mulago, Kampala, but it's usually what we think about when we think about Haiti, when we think about maybe Guyana, when we think about Malawi, when we think about Congo, when we think about all those countries in Southeast Asia. But I think COVID-19, really, we have to be a little bit more critical. On the left is a mother who's actually, it's the same mom in both photos. This is her coming in all the way from Jinja, having gone to about 4 regional hospitals in Uganda amidst the pandemic. And nobody could really help her. So she finally lost her uterus. She's had convulsions, which can be controlled. And the last photo is this mother being discharged, still in the COVID-19 pandemic. That's her husband and that's her. And I remember when we were taking these photos, I was taking these photos and getting permission from this mother and saying, you know what, just allow me to take these photos. I think one day we can share your story with the rest of the world and it may mean something. So I'm really glad. Thank you so much, MacGlObAS, for giving us the opportunity to share these experiences and to share our analysis, our experiences, and what we really think global surgery has to learn and has to benefit, has to adjust post-COVID-19 pandemic and amidst the COVID-19 pandemic. Next slide, please. David, if I could have the next slide, please. Are the same, whether you're in Canada, whether you're in America, Sudan, DRC, Guyana, the issues are really the same. And I think this is an opportunity for us as global surgeons to pick a few lessons. If we look at the COVID-19, SARS-CoV-2 pandemic, it's the redirected focus. It's like the world has never had any health emergency aside COVID-19. But we all know, we all work, we've all experienced global surgery. And I think for me, having those months I spent in McMaster, I learned that even when you're in North America, there are challenges. They're just uniquely packaged, but all of us as global surgeons, we face our own unique challenges. The amount of documentation I saw in North America, I don't know if I can be a surgeon in North America. And I mean, it's very good to document, don't get me wrong, but I mean, and the level of litigation, and you know, that like the fact that you have to be very careful. We are very careful, but you get to learn that at the end of the day, even as global surgeons, we have the same story. So how do we deal with things like the redirected focus, political will? COVID-19, everybody just had every politician was only as relevant as their rhetoric on COVID-19 pandemic. And those, there's really a lesson for us to learn there. The news headlines, have never really been so much about a health issue. And of course, this was a pandemic, and of course it hit the economy, the tourism sector, and all kinds of players. I mean, Wall Street was brought on its knees. So we understand why it made headlines. But again, the bottom line, it's health. So people have their attention on health matters, and health is global. Something which goes wrong in China or in Uganda or in Sudan or in DRC can be a global health emergency. Some of the underlying issues here, again, as we appreciate and look at global surgery, COVID-19 pandemic, what can we learn? What can we do differently? Prioritizing of the mega resources, including human resource. And, you know, PPE has been PPE, but I think for us in particular, as people who are in surgical disciplines, and for those of us who are in, and it was no longer there's limited PPE in a low resource setting. Each time I would watch news and I would see PPE was a cry all over the world. But again, we're uniquely affected because if we look at the appropriate PPE for COVID-19, especially in the index phase when everybody thought, you know, how do I dress myself? What is appropriate for PPE? Is a mask sufficient? Do I need a suit? Do I need to scrub? But whatever was needed is actually what is needed in surgery. So that became an issue also because in low resource setting, when you take away what must be put on to conduct a safe surgical procedure, and now this becomes what must be put on to, you know, stay safe from COVID, that becomes, you know, an issue. The loss of income that was global, much more felt in the low resource settings because of the, you know, there's no minimum wage, and a number of developing countries, especially in Africa, the hospitality sector was big, tourism, people coming to the parks, that was no more. And that had its own implications in access to surgery and timely care and funding and things like, you know, am I able to move? Because at the end of the day, everybody, this money goes around and the strain could be felt. For us, it was issues like shortage of blood products because most of the people who give these donations are students who are in schools and institutions. The lockdown has such implications where you don't have organized public transport in line with delays in accessing care, but also unique in our setting, something which really came up. And as surgeons, we've always thought, people in surgical disciplines are like, yeah, those are social science issues, gender-based violence, forcing people to stay at home. All of a sudden, gender-based violence was the biggest issue, the biggest cause of trauma. You know, people were coming, and those of you are, you know, reading a lot of international news, amputations, you know, deep cut wounds. And that was just gender-based violence from people staying with their maybe spouses for so long and all those issues of rights. We've never really thought that gender-based violence could relate to us as, you know, surgeons, obstetricians, and physiologists. But for us, we've seen a lot of that relating to trauma and, you know, delayed access to care. And the root cause was gender-based violence. Next slide, please. I wanted to share a few contexts in terms of opportunities for global surgery. What does the year 2020 have to tell us? In our settings, and I think that's where I think, despite all the challenges, of course, like you all know, maybe we think we are overly a bit spared compared to what the numbers we saw in North America, Western Europe, but also we appreciate that maybe we're not doing as much testing as the developed world has been doing. But irrespective of the much testing, on the overall, our numbers were not too huge, because we've seen our colleagues in Kenya who have produced their studies that even if they looked for antibodies, they're looking at a prevalence of about 4%. But as surgeons, we were brought to think about issues that in low resource settings, we sometimes think we don't have access, maybe we have limited resources. But I think there are opportunities which the COVID-19 pandemic has shown us. And I just summarized a few here. Shortening hospital stay. With COVID-19, it didn't matter. Like, you wouldn't stay. Like, who would like to stay in one of the ground zeros of COVID-19? So all of a sudden, we realized that some of the planning issues, like strengthening the case for planned surgeries in low resource settings, that you mobilize the meager resources that you have, that the patient will walk in, whether you're going to do a minimally invasive procedure or it's a long procedure, strengthening the arguments for cases of hospital. What else can we do, you know? And during the pandemic, and actually up to now, we're not having patients stay for long. But before, many of you have done a lot of international work where you go bedside and somebody is waiting for a surgical procedure, elective, and you're like, yeah, we are still waiting for the hemoglobin. And you're like, you're waiting for what? Hemoglobin? Like, does she have to stay in the hospital waiting for a complete blood count to be done, you know? So I think now as we repackage the interventions in a cost-effective manner, the population will understand more. But I also imagine that all those who are interested in working with global surgeons, some of these things will no longer have to explain in so many ways. They would understand why the shortened hospital stay, why the case for planned surgeries, appropriate anesthesia. My colleagues on this call, the anesthesiologists, who have done a lot of international work, I'm sure a few years back you'd really be like, why are you intubating this patient? Just give spinal. And they're like, yeah, you know what? I think I want to intubate. Not anymore. Actually, one of the arguments we have right now is anesthesiologists saying, you know what? I can never intubate. Just show me your COVID-19 test. And of course, that makes sense. We all understand. But also, health. It's really high time that we really strategize on e-health, whether it's going to be in line with training, virtual training. And I'm glad that somebody was asking, I think you're asking Dr. Shan about what have they done, these electives we used to have in Canada. How are we planning? But as global surgeons, people in surgical procedures, disciplines, we need to appreciate the role of e-health, whether it's going to evolve around patient consultations, investigations, pre-surgical counseling, name it. But also community-based solutions to surgical problems. Because all of a sudden, all the populations now appreciate the implications of delayed access to essential surgical procedures. There's big role for simulation surgical training and student-centered learning. Even in the medical, you know what? I think we have to show the students. We must be there to teach our students, which is correct. But maybe now a number of our students are going to have to watch a certain number of videos, a certain number of procedures, because we are now seeing how you can't social distance and you can't, you know, do virtual training entirely for surgical disciplines. But I think, again, a big opportunity for mixed model learning and mentorship. And I think for me, these are opportunities which we have to consider. Next slide, please. Next slide, please, David. Thank you so much. Access to essential surgical services. This is a mother we attended to with a team when everybody was like, stay at home, go to the hospital at your own risk. You know, really at the peak of, we're still having a lot of cases of COVID-19, but maybe we have a better understanding of what it is that we need to do. But this mother story represents a number of stories across the world. In particular, I'm an obstetrician gynecologist, so of course this is an obstetric case. This is a lady who stays on the islands of Lake Victoria, Kalangala, a beautiful place, but access to health care is not guaranteed. Now, it's one thing to stay next to Lake Ontario. It's another thing to stay in the islands of Lake Victoria in East Africa. So she goes into labor. You know how it was with COVID-19, everybody go to the village and everybody try to go where you think you can stay for a longer period of time. She's not able to get transport. Finally, she gets transport. You know, they're talking about boats, but they're not talking about maybe motorized ambulance boats. But you can imagine the kind of canoe which eventually gets her to a regional referral hospital in Masaka. By the time she gets there, again, the COVID-19 pandemic, not all the required human resource, key human resource, were able to stay in some of these hospitals. She has a ruptured uterus. She has a vesicovaginal fistula. She has a rectovaginal fistula. She was brought to our hospital. And this is me, of course, seeing her and counseling her. And, yeah, we are working on and we are planning, what do we do first? In the middle of all that, the immobilization and all the issues, she gets massive DVT. Now, we are all surgeons. It's one thing for you to handle massive DVT, but I think you just say, you know what, where are the hematologists? I need a consultation to the hematologist. This was all up to us, So I think, I feel that as COVID-19 tries to help us replan, re-strategize, see where we need to lay emphasis, what do we need to focus on as we plan increased access to essential surgical services, as we plan training of critical healthcare workers, as we plan decentralization, because I think this has been a big opportunity to tell us that, you know what, no matter where you are in the world, you better have fully fledged surgical units, emergency resuscitation units all across your country, and a workforce which is ready to handle. But for her, it was also telling the story in the local language. That's the brother and the husband. Of course, in the middle of COVID-19, like issues of male access, there was nobody to come. You had to come. But these two men became and now like lead advocates of the need to access essential surgical care services in time, because they saw what it cost them. They saw how long it took, the fact that the patient didn't have a timely cesarean section. And now she's ended up with everything that she's got and more. And I just remember a time when you have limited capacity to investigate. You can imagine if you're putting somebody between low molecular weight heparin Clexane, and then you think, oh, I think we need to go to warfarin, and you're not monitoring your INR. You know what all that means? At one point, we actually ended up with now a massive bleed, and we're like, okay, now where do we get the INR from? So, and they appreciated that if you don't have timely access to essential surgical services, you pay a very heavy price. And I think for me, that is also very critical. Our colleague was sharing about Kiowa Hospital and so many languages that people speak, and that's very true. And so translating this in the local language, but also local language in terms of country context, appropriate community engagement in understanding surgical management. As surgeons, we kind of like speak to each other, which is not a bad thing. That lady in the middle is a journalist, because we got to a point where we had to tell the politicians the story of appropriate surgical management and timely surgical management. And a case like this one of Dinavins was a good one for them to appreciate, that a cesarean section would have saved so much. She would have had a baby. She wouldn't have had a vesicovaginal fistula. And when they saw she was leaking urine, she's leaking feces, and we're telling them, no, we can't do the two at the same time. And then all of a sudden she's in ICU. We're like, no, this is something else. She had massive DVT, and we think she's getting a clot. And they're like, is all that related to the failure to have a timely surgical procedure? So getting the community and the leadership to understand what is the need and what does it cost if you don't have timely access to essential surgical care. The next slide, please. And honestly, I think these are all the opportunities amidst this is the glass half full or half empty that COVID-19 presents to us as global surgeons. So what does it mean amidst this COVID-19 pandemic and surge? Access to essential surgical care. We need to redefine who the key stakeholders are. And I really deeply hear all my colleagues who have presented before, the need for education and training of the next generation. In Uganda, 2 weeks ago, we celebrated neurosurgery. And Professor Brian listened to this very attentively. I'm sure you read the story already, and your girls and boys must have been part of the team. But these are Siamese twins, and who are the people doing them? One of them is my classmate from Barara, Dr. Onen, who was in Kiowa, went to Morocco, Peter was also in Cuba, then went to Cape Town. These are just colleagues who have had placements in McMaster, in Cape Town, in Morocco. And when they come home, COVID-19, there was nobody to call. Nobody was going to get on the plane to come because this is the planned time at which these Siamese twins had an opportunity to be separated. And these colleagues were very successful. They were celebrated. This is a few days ago in the middle of the pandemic. So I really think we need to redefine who are going to be our critical key stakeholders. What is going to be their role? What are the bottlenecks that we need to deal with? And to the credit of St. George and McMaster, honestly, the fact that you allow us to follow you through the operating theaters, the fact that you allow us to assist you, and I know that's big in North America to allow some doctor who has come from Africa, didn't train in North America, and to follow through a procedure. Those are critical things in mentoring the next generation. We learn so much. Sometimes we know, but we get more confident, okay? Redefining the definition of access. Is access incision time? Maybe not. So maybe we need to redefine what do we mean by access to essential surgical care services. Dinavens above there is a good example, DN. Maybe access meant she didn't have, if she was to access essential surgical services, she needed to know in time that she didn't need to leave where she was living if she was scheduled for a possible procedure in the next 3-4 months. So you may find that maybe it's not going to be incision time anymore. How much information is out there? And then it is going to be more than physical presence of the clients and the service providers. Repackaging the components of essential surgical care services and the timing of access. What do we mean by timing? To which part of the component of essential surgical care services? COVID-19 pandemic has helped the political leadership globally to appreciate the priority of expansion of critical emergency care services, surgical, medical, but also key there, competent, decentralized teams. And I want to, whether decentralized teams means that there is a competent team of people in China, in Uganda, in Canada, in Luxembourg, in Germany, in Guyana. Like, we really now have to know that on top of the country specifics, then in country, Uganda has been a very good example. Our politicians didn't know that ICUs, maybe they knew, maybe they didn't appreciate that ICUs are needed in every regional referral hospital. In the middle of COVID-19, an ICU was set up and fully equipped in every regional referral hospital. And then next we're told, you know what, you need an anesthesiologist. And they're like, who is that? Now, can you imagine if the lead political teams who are making critical decisions have never even got to appreciate the importance of well-trained, motivated, equipped, competent, decentralized systems? We need to ride on this pandemic to let them know that that was long overdue. The last bullet there, I think, is going to be the hardest. A paradigm shift for us, the senior surgeons. You know, there's a way we do our things. There's a way we work as people in surgical disciplines. But I think it's time now for us to unlearn and to learn. Some things we have to unlearn, some things we have to learn, because I think this pandemic, with all the pain and all the trauma and all the disruption that we think it has brought, I think it has brought some opportunities for us as global surgeons to ride on. And finally, as I go to the last slide, David, next slide, please. I love this picture. And my Canadian colleagues, you can't get away from this. I think the last time I was talking at MacGlObAS, I talked about athletics. Looks like I have to talk about athletics again. This is Cheptegei, and those of you who don't know athletics, is Ugandan, of course, and is broken 2 world records in the middle of the COVID-19 pandemic. I was in my house and Cheptegei was being interviewed. Like, Cheptegei, this is now in Uganda. Are you sure you can do this? it was this answer which I just laughed out so loud, because Cheptegei said, fellow Ugandans, my worry is breaking the world record in the middle of COVID-19. If only I can get the means of transport, that there is a plane which can get me from Entebbe to where I'm supposed to break the world record, the rest is history. Cheptegei broke 2 world records. We are in the middle of a pandemic. There are all this. I can imagine when our colleagues were doing the sustainable development goals, go back to the drawing board, how many people would have slipped back into poverty, how many people would be told to us, can no longer access essential surgical services. But even as global surgeons, in the middle of the COVID-19 pandemic and beyond it, we can still set world records in global surgery. So thank you, colleagues. Thank you very much. Asante sana. That's how we say thank you in East Africa.
Well, thank you to Dr. Madison and to Dr. Nakabembe. Those were excellent presentations. I'd like to open the panel for questions. I do have a question myself for Dr. Madison. Can you share with us how your fellowship experience has been impacted by the COVID-19 pandemic? And were there any valuable outcomes, positive outcomes from the experience?
Yeah, the impact of COVID-19 on my fellowship was, I would say, it was a little bit higher in the beginning of the pandemic. But then, because I'm doing trauma and the operating theaters are running during the time of COVID-19, because we cannot postpone all these trauma cases. So the effect on the volume of procedures that are going in was of course impacted, but not that severe. So the biggest challenge was on being able to do elective cases, which is probably maybe 25% of my target, but I was able to continue doing, being involved in emergency and trauma cases. So the impact was not that huge. But again, I mean, it was a great experience for myself, learning how things are properly done, because in our setting we usually work with the scrap that we're given. We have little resources, and some of the things that we study remain in the books. Like, we don't implement them because we don't have enough resources to do that. But coming here, I was actually able to be exposed to this kinds of procedures and patient care and all that. So it was really a rich experience for me. It also helped build my confidence a lot. So I'm 100% sure that when I go back, I'm going to be a better surgeon.
Further to that, you mentioned, of course, that that the elective surgeries were eliminated essentially, and I think that had a significant impact on orthopedic surgery. So, do you think you had more time, therefore, to learn? There was less. Oddly, there was less pressure from the operating room for these trauma cases, because that was the main activity as far as the orthopedic service was trauma. So do you think you had more time to learn, and there was more emphasis on the education that there might otherwise have been not have been if the pandemic hadn't taken place?
Yes, of course. I actually had that very good balance because it's usually very important that when you do a procedure, you go back and try to reflect on it and see what have you done wrong and right. So it was about that balance was almost there. Although I admit that during the beginning of the pandemic, actually we had to spend like 2 weeks in the hospital and 2 weeks off the hospital. So that was a little bit difficult. But as time went on, actually that balance was there. The only maybe difference was that there were more bodies, more people around in the theater, being involved. But I do agree that it helped me uh, get things right, like not to be pressurized in terms of being in the operating room all the time, and forgetting not to go through my books and all that. So that was a good balance for me.
Thank you. There is a question from Dr. Cameron. Would you like to ask it yourself, Brian?
Sure. Well, just sorry, specifically, I guess, Brian, I enjoyed your presentation, and I was wondering specifically about implants and the availability of implants. And of course, one of the things that COVID has done is affect our supply chain for various things. Do you think that that will change how you use implants? So you'd be more likely to reuse implants, for example, when you go back in your setting? Will it change practice in that way?
Yeah. It actually this COVID situation actually opened up my mind to a lot of things. Traditionally, I would think that high-income countries like the US and Canada have everything available on hand. But during this pandemic, I actually experienced the fact that Canada can have shortages in small things like gowns, masks, and all that. So it's eye-opening because that actually gives me that sense that when I go back home, I need to make sure that the little resources that I have, I'm able to use them, in a good way. Try not to waste things and so forth. In terms of implants, trying to reuse them, that's actually a big challenge. Back in Tanzania, when I was doing my residency, we would actually reuse the implants, including nails and plates. But when I started working in South Sudan, it was a little bit different because we somehow had a steady supply of some of the essential implants, especially like the sign nails. They're always there, so we didn't have to reuse them, and the plates we didn't have to reuse them. But of course, we reuse some of the screws, which sometimes end up breaking. So overall, I think I'm going to be more economical managing my my little resources that I have.
Okay, thank you. Dr. Chamberlain.
Great. Well, thank you so much, Dr. Madison and Dr. Nakabembe, for those really excellent presentations and your reflection there that indeed in Canada and other high income countries, there can be shortages as well too. And I think we have lots to learn from one another. Dr. Eve, I couldn't help but think that it would be a good idea, even from a presentation like today, for some people in the group like this to even put our heads together and do some writing about some of these really important reflections that you've made. These are lessons that people from around the world can learn. So thank you very much for sharing that. And I hope that that comes out of this presentation that we've really all enjoyed having this morning. Thank you very much.
There is another question in the chat from Mark Osmond, and I think it's directed at both of our speakers and perhaps all of the speakers. Just wondered whether COVID has affected the public and patients' attitudes towards health workers in Uganda, South Sudan, and Guyana. It's been variable, very variable in Canada and the US. Dr. Eve, perhaps would you like to comment? about the effect that COVID has had?
Absolutely, yes. Absolutely, yes. Yeah, I was saying to question, and the answer is absolutely. But at the beginning of the pandemic, we had the public in Uganda. One bus company in particular just to take healthcare work. There's never really been an opportunity for the public to know what is the other side of the story, apart from, rude, harsh, don't have services at all times. And now all of a sudden people appreciate the risk, the need to see my hospital. Actually, we lost the principal hospital pharmacist on Saturday to COVID-19. I've had a number of my colleagues admitted, some in ICU, some have recovered. And that, we literally risk our lives to offer what we offer. But also they now see that they have a role to play. They have a role to understand what is it that is needed. Almost all the disinfectant, the PPE, and for us in particular, Uganda, we've started in the last 4 months, factories have been built to make surgical masks, gowns, disinfectants, because then we could no longer go to China. We're no longer receiving donations. So all this gets the public to appreciate what could be their role, and also to understand that healthcare workers sacrificing quite a lot. That said, also to the contrary, there have been some views. Last week, others were presenting with severe COVID symptoms. And the health workers are scared. They are still very scared. And one mother in particular we lost on Tuesday. She needed to have an emergency cesarean section. She was in 4 big hospitals around Kampala, and none of the colleagues felt comfortable with the PPE they had. The particular hospital we had isolated to manage emergency obstetric cases with severe COVID, I think, was out of oxygen. But then it was also a reality for us to know that now this is community spread. COVID-19 is everywhere. How much are healthcare workers willing to risk? And there's been an element of that maybe the surgeons, we're insisting, surgeons means all of us, general surgeons, neurosurgeons, orthopedic surgeons, pediatric surgeons, obstetricians, have a COVID test, and that rubbed off very wrongly with the people who needed emergency surgical services, because the COVID tests are not available. If I know if they're COVID positive, should they need intervention, I know the level to which I should, don myself. So there's been also the element of the healthcare workers have surrendered. They can't work on us if we are quarantined, has affected the attitude. Yeah.
Are any of the other speakers there that wish to make a comment on that question?
Yeah, if I may share about something about South Sudan. So one of the issues in the beginning of the COVID-19 pandemic was the fact that doctors were there trying to work without enough PPEs being provided to them. They don't have health insurance coverage, so it was a risky situation as a whole. But the problem is the people, the public, at the beginning, they did not appreciate the fact that the problem was not with the doctors, but the problem with actually the healthcare providers. So they didn't know that the problem was not with the doctors, but the problem with that the government is not funding. So people thought, okay, doctors are out there, they don't want to work and all that. But with time, as more information came out about COVID, they realized that actually the doctors are trying to do their best. So it's just a little bit different for us.
There is another comment here from Dr. Wong, Ann Wong. One recurrent theme in Canada and US is how COVID has widened disparities among populations, subgroups, including gender disparities. Has that also been the case? Presumably elsewhere? Anne, do you want to elaborate on that? On your question?
Thank you, Carolyn. Sorry, you read my question earlier than I was able to type it out. But yes, has also been the case elsewhere in the regions that all of our, I really, actually, before I even start, I really enjoyed all of the speakers. It's really been a great conference. But yeah, I'm just generally asking this of all the speakers, but specifically Dr. Eve and Dr. Brian.
I'm not sure if
thank you.
Sorry, carry on.
Thank you so much. Uganda is a very good example. I work in the Mulago Specialized Women Unit Hospital. It's a very good hospital. Colleagues who have visited of recent can testify to that. As of 3 weeks ago, we were told to close down the platinum and gold suites. These are suites which you have self-contained rooms, you have oxygen, you have all these things. For the politicians, the political who could no longer travel out of the country, it is real, you know. And we've had this debate for 3 months, and we're like, you can't do this. This hospital is for women, like the one I've just shared, who get these complications and need a multifaceted team. And they said, no, we can't surrender all the political leaders, the ministers, the ambassadors, the members of parliament who can no longer leave the country. And that is just one of the examples of really widening these disparities among the populations. Gender is a complex one. And I think moving forward post-COVID, I think gender is going to be really mainstreamed. But I think I'll just let my colleagues from Sudan and could also share their own experiences.
Yes, Dr. Swan has raised her hand. I think she's going to comment. Dr. Swan, are you there?
Can you hear me?
Yes, we can.
Okay, great. So I just wanted to make an input in the previous question in terms of what is the perception of the public, their attitude towards healthcare workers. Here in Guyana, I think that the overall sense of the public is that they have not fully accepted the gravity of the pandemic of COVID-19, what it all entails. So generally, people just have a really laid back attitude towards COVID-19. Some have even, they're still in denial in terms of, you know, whether or not it exists. So overall, I would say that they haven't grasped the level of risk, you know, to what extent we are actually putting our lives at risk each day that we have to go and care for those patients, and even more so that we can be so overwhelmed, and we have our families to think about. So overall, I don't think that has dawned on many persons in the public. As it relates to our political situation, we have a somewhat volatile situation that is beginning to improve at the moment. So we're looking forward to some positive changes. but we're still pretty much in the dark, and nobody really, overall, then the public, they do not really give us much mind.
Thank you. Well, we've used up our time, and I want to make a few remarks before we all say goodbye. You will all receive an email on Monday, I believe, from David that will have a survey and evaluation of today's symposium. So we encourage you all to complete that. And as well, the video from today will be available as well. It will be on the website under the video resources tab. So we encourage you to review that and share that with your colleagues if you wish. So this concludes our third annual MacGlObAS Symposium, and we're really very delighted with the participation today and your interest. I'd like to thank my co-moderator, Dr. Joel Hamstra, and echo his thanks to our leader, Dr. Brian Cameron, who continues to inspire many of us to pursue and advance global health and surgery initiatives here and abroad, both in person and now virtually. As mentioned, this symposium today is entirely possible because of the work and dedication of David Oldenburger, and we're very grateful for all his time and commitment. We're very, very grateful to the presenters who have shared their insights and experiences with us today, both here and from afar. And I think that the challenges of communication across the world has really they've improved significantly, and so we've been able to share all this today fairly easily without too many technological challenges and glitches. I think as we go forward, we should consider something that was said by one of our speakers today, that we can look at this global pandemic in a different light, in addition to the tragedy and the complexity that it's added to healthcare and day-to-day life for all of us. We can look at it with a glass half full attitude that Dr. Eve talked about, and hopefully some positive outcomes will occur, and we will continue to strive towards finding the good that may come out of this. As we all continue to navigate the challenges that COVID-19 has presented, it is of some comfort that there are others around the globe who share the common interest of advancing health delivery and education to as many as possible. On behalf of Joel Hamstra, Brian Cameron, and David Oldenburger, we thank you for your participation and your interest today, and we wish you strength and good health now and in the coming months. Thanks to everyone.
Thank you
Thanks a lot.
so much, and bye.
Everyone.
Thank you. All the best, everybody.
Thank you.